So we're here today with Professor Janet Treasure and Dr. Hubertus Himmerich, and we're going to be thinking about some of the questions that carers and patients with eating disorders have about medication and therapy for eating disorders. We might cover some other topics as we go along, but that's going to be kind of the focus of this little segment. So thank you for joining me.
Thank you.
So one of the questions that people I've worked with eating disorders and their carers have often brought up is, if I take medication, what will it do? Will I get addicted to it? You know, will I have to take it forever? And I was wondering, in your experience, whether you could say a bit about whether that's true and whether that's supported by the scientific evidence.
You're correct. That's the main question, isn't it? This fear of getting addicted. And it's a bit ironic because, of course, in a way, the eating disorder behaviours are rather addictive and are very difficult to shift. So that's one thing. But the other thing is that there is no evidence that the drugs we tend to use are addictive. In fact, there's a lot of evidence that the drugs that we might be thinking of using, such as antidepressants, one thing they do is help stimulate nerve growth and new learning, which, because of the starvation, gets rather stunted. So they allow more flexibility and a change of routines rather than keeping this sort of chronic overlearned pattern that the eating disorder is. But maybe Hubertus can explain a little bit more as well.
Yeah, if we look at the medications we prescribe for our patients on the ward, we see that we prescribe a number of medications like promethazine or omeprazole for the consequences of the eating disorder.
And it's palliative.
Yeah, and therefore quite often patients receive so many medications anyway, and it would be strategically better to just prescribe the one medication which helped a core symptom of the eating disorder. There's no medication approved for anorexia nervosa, but there is medication for certain symptoms, for example, medication for anxiety, medication to help with sleep, and depending on the individual patient and her or his problems, we could think about an individualized care plan that includes a medication.
So it sounds like medication is one of the potential things that families could consider, and often when people come into treatment they might be taking lots of different tablets for all kinds of different things, whereas there are some psychoactive medications that might help with some of the underlying anxieties, and that could be an option for some patients.
Yeah, absolutely. For example, olanzapine is an antipsychotic medication that is currently used for schizophrenia, but it helps with anxiety, it helps with sleep problems, it helps to concentrate better, so this could be an option in anorexia nervosa. And quite often patients take a lot of other medications, for example antidepressants, which do not help if the patient is underweight and the brain does not have enough protein or enough amino acids to produce the neurotransmitters which are targeted by a certain antidepressant.
And yes, if I could perhaps clarify that, most of the antidepressants act by blocking reuptake. So you've got to have enough going in the system before it's going to be effective. Because
the serotonin.
Yes, serotonin, or it could be dopamine, or some of the others. So just by stopping it coming back into the cell, but if you've not got very much going out, it won't have any effect, because these are amino acids, part of proteins, that everything is depleted in the body, so you're not able to produce it. So people are now thinking we perhaps need different sorts of antidepressants that are used for treatment-resistant depression that act more directly on the receptors rather this indirect route.
Yeah.
So I think we've got a rather squeaky table in your office, Janet, so we might have
Sorry
to move
about that,
back a little
I
bit.
won't put my elbow on it,
It's really interesting that some of these medications that people might have tried before weren't, so we don't think they're as effective as they could be, because people are very underweight and they haven't got enough of the chemicals, I guess, in their brain in the first place for them to actually work. Whereas something like an antipsychotic medication like olanzapine might act in a different way and might help to reduce anxiety and help people sleep. And I've heard of olanzapine, and lots of the people I've worked with have raised kind of concerns like, well, if I take that, won't I put on loads of weight? Because that's what I've kind of read online and in forums. And I was wondering whether there's any truth behind that for anorexia.
Weight gain with antipsychotics is very interesting, and it's an area that's just being evolving, because, for instance, people with black ancestry are most vulnerable to it, whereas white populations aren't as vulnerable. And also we know that the genetic profile, metabolic profile in anorexia would be the sort of one that would make them very resistant to the weight gain. And in fact, this is what is found, because not very much weight is gained in the studies on it. There might be a tiny bit, but it is not the big problem that it can be for some individuals.
Yeah, exactly. As you say, people with schizophrenia are genetically different from people with anorexia. If you look at the genes, metabolic pathways, and therefore you cannot say people with schizophrenia gain weight if they take olanzapine, and that means that people with anorexia gain the same amount of weight. In fact, as Janet has told us, people with anorexia gain much less weight than people with schizophrenia under olanzapine. But even the slight weight gain, let's say 1 BMI point, can mean a big difference in terms of quality of life, or being strong enough to live independently, or get back to the old roles at work or in the family. So even a slight weight gain under olanzapine can make a big difference.
Because we're talking about inpatients having about 7 BMI points below their normal weight, aren't we? So the 1 BMI point is a tenth, or a bit more than a tenth, isn't it, of what they've lost. So we are talking about minor effects. Unfortunately, if you want to get people healthier with a better, normal metabolism, they don't do this.
But we should not talk too much about side effects and lose the effects we wanted, because some of the patients really like olanzapine and like that it helps with anxiety and it helps with sleep. So even if we tell them after 8 weeks or 10 weeks we would like to try without olanzapine, they say, no, please, that olanzapine because it helps me with my psychological symptoms. That's another topic to think about, the length of treatment. I think this is different from psychosis. We would only prescribe olanzapine and anorexia for 10 weeks or 16 weeks or 3 months, and not for a year or 2 years, because there's no evidence that this would be beneficial.
So people would perhaps consider taking it for a fairly short term, for a specific reason, to help them to feel less anxious, to help them to feel a bit calmer, and to remove the need for other drugs, like you mentioned, promethazine, which
sleeping pills,
zopiclone, and benzodiazepines. And we think that one of the ways it acts is it helps to sort of reduce that kind of anorexic voice and reduce some of the anxiety, and that might help people to have a better quality of life kind of during their recovery.
Absolutely. It also helps to focus your concentration, so that can be beneficial for psychotherapy. And if they are less anxious, they might try new things, like increase their variety of foods they are eating. And once they have achieved that, after a few weeks, one can start to stop olanzapine or reduce the dose.
I mean, that would be a real gift, wouldn't it? Because a lot of people say, you know, I can't even concentrate on a book, and I absolutely love reading, or I want to write in my journal, but my mind just drifts. So improved concentration sounds really helpful. One of the questions that families often raise about medication is about how other people might perceive their loved one if they were taking something like an antipsychotic medication. And I wonder, in your experience, how you might help patients and families to think about that.
Yeah, quite often people think about the old antipsychotics, like haloperidol, where people were quite stiff and could barely walk, and they had the same symptoms as people with Parkinson's disease. But we now have the second generation antipsychotics. They don't have these side effects, and therefore you can't tell whether someone is on a certain drug or not if they take these novel antipsychotics. So other people wouldn't know. It's rather the opposite is the case, that if people seem more alert and less anxious, then they might make a better impression in their environment.
It is a bit unfortunate with the naming of psychiatric drugs that we have these arbitrary things as if it's to help a certain condition, and that's really not the case. We really haven't got a specific silver bullet for this diagnosis. As Andreas was saying, it's much more...
Hubertus.
Oh God! It's
all right, Janet.
It's much more sort of specifying a certain process, such as anxiety, such as difficulty sleeping, and it doesn't mean that you're psychotic because you're taking an antipsychotic. I mean, so it's a bit of a misnomer, really. And similarly, the antidepressants. I mean, they're often used for anxiety more than depression. So it's we haven't got a good system of labelling them, really. So I think that gets people uncertain, confused.
I guess there's a lot of medications like that, aren't there, that are used for, have lots of different uses, and maybe these ones that act on our psychology and our brain are just a good example of that, and the labels are perhaps a bit wrong.
Because what I'm saying is now we know the mechanisms of some of these antidepressants, which is neurogenesis, dendritic spike formation. Perhaps we better call that rather than depression or something. So I think there's a lot of new work getting us to understand what these drugs do.
Yeah, could you say a bit more about that, Janet? That sounds really interesting. So you're saying that these drugs are getting your brain to kind of generate new cells or new connections between brain cells?
That's what they're finding a great deal seems to be the mechanism of action. And if a drug doesn't do that, it tends to be not effective. So there might be counteracting things in the serum, sort of immune or high levels of stress, which stop the good effect of the antidepressant, and so you might need a different form of medication in that case.
And that's what something like we think olanzapine might be doing, something like that.
Something like olanzapine, or there's even newer drugs, even sort of magic mushrooms and ketamine. People are very interested in these new sorts of drugs.
Yeah, I would like to underline what Janet just said about the categories of medications. For example, if you look at fluoxetine, which is an antidepressant.
That's what people might know as Prozac, isn't it?
Yeah, and how that helps people with bulimia nervosa.
Yeah.
So it helps with these binge eating attacks, but it doesn't help that well as an antidepressant in bulimia. So
different doses.
Yeah.
Needing different doses than people with depression.
So different antidepressants might help people with different diagnoses differently. So an antidepressant might act differently in a patient with bulimia or in a depressed patient and anxious patient. So it's always a quite individualized decision and also a bit of trial and error. We can never predict 100% what will help or what will not help, and therefore we'll monitor patients and support the families and ask about how the medication is. We talked about side effects earlier. I think that's a topic we should address again, because some of the side effects only appear in the first 1 or 2 weeks, like fluoxetine, where you can suffer from dizziness or nausea. And we have to help the patients to overcome these symptoms, because they will cease after 1 or 2 weeks, or but in most cases after a few days.
It can be quite difficult. I guess you've taken this new medication and then you're noticing its effects on your body, but you're not necessarily getting the psychological benefits yet. So then you have to sort of persevere through that phase. What you're saying is actually the benefits will come when you kind of reach the therapeutic dose, when you've got the right amount of, or the needed amount of that drug in your brain and your body. And then those side effects will go. And so, what kind of working together to support people to kind of manage the nausea if they experience it. Yes,
it's very difficult to get the exact dose of drug for the exact person, because people's brain metabolism differs, but also the way they get rid of any drugs, the liver, how the liver works. So some people metabolize things really quickly, and so they have very low levels, and you have to give higher doses, and some are the opposite. So that's why we tend to start low and gradually, but then that means people have got to wait a long time, perhaps, if they're people who, metabolize it quicker. So that can be problematic. It's not so easy. We can do some genetic testing for that, but you still have to wait for the results and that sort of thing.
It's a bit more towards personalised medication, personalised psychiatry.
That's exactly right.
If someone shows severe side effects, we can measure the level of that drug in the blood and see whether it's because we have prescribed a too high dose of this medication. So this is possible. But sometimes people have severe side effects without a dose that would be too high, or at a very low dose, because even placebo can do side effects. So in all the randomized controlled studies, you see that even people on placebo have side effects. And
so the placebo is like the kind of sugar pill, isn't it? It's the thing that we're comparing the active drug to. So people are still experiencing some strange side effects when they think they're taking the drug. So part of it might not be physiological, perhaps.
Some of the side effect is just a result of the expectation of side effects. And therefore it's important to stay in contact with the medical doctors and report those side effects continuously, and then we can help patients to get through it, or we have to stop the medication if these are real side effects.
Yes, it's unfortunate, isn't it, that some drugs, there are some myths about some drugs, the myth of addiction, the myth of going to gain a huge amount of weight. Which is unlike immunization, the way that there's big myths about that. So there's some things that a society gets frightened about, not related to the medical facts, and can really interfere with helpful treatments, which is problematic.
So these sort of poorly informed or misinformed negative beliefs could prevent people from actually accessing something that could be really helpful.
Yes,
Yeah.
yes, I think that's what we'd say, yes.
I wonder how we help people overcome that. I guess sharing information in this way might be one way, but I guess the other thing we're asking people to do is a bit of an experiment and test out whether this medication is going to help them a little bit, because I don't think we're saying that it's a kind of panacea, that it's going to cure anorexia overnight, but it does sound like it can be a kind of tool in your toolbox that you could use to help your brain to be a bit different, to make new connections, to generate new cells, to help you learn. Because that is one of the really sort of tough aspects of anorexia, is that you're having to relearn or unlearn behaviours, but your brain's not in quite the right shape to do it. So it's kind of like being asked to run a marathon when you don't have the right shoes or the muscle strength, isn't it?
Yes, we know that fear memories don't seem to be able to be lost. They sort of stick around. So no amount of psychotherapy, which is helping people try and modify those, works. Or it might work in the moment, but it doesn't work the next day. Or in a different context. So trying to help overcome that.
That can be so frustrating for families, because you sort of think, yes, we've done this meal, we've managed this pizza or whatever it might be, and then the next time you have to face it, the fear and the disgust and the anxiety are all still there.
That's right.
And that might be because of the brain being so depleted. And these medications could perhaps help a little bit in relearning or learning that these things aren't as scary as the eating disorder says they are.
That's right. Yes, because we know that all getting rid of fears is learning new expectations about the feared thing. So it involves new learning, and if you haven't got metabolism and enough energy in your brain, you can't learn well.
That's maybe something to point out, and I've learned that from you, Janet, that nutrition is the main medication for patients, because it helps all the deficiencies and it helps the brain to work properly. So this is something we need to highlight.
Nutrition is a medication in itself. And we really do see that on the ward, don't we, when we've had people who've been really malnourished and they start to sort of re-nourish their brain and body. They start to think a bit differently, they become a bit more flexible in their thinking, they're not so stuck in all the details, and they can actually plan what they want to do with their life and how to build it back up again.
For the majority that's the case, but we do have those where it doesn't, doesn't it? Even after weight gain they still cannot do that future thinking, they can't imagine a non-anorexia identity. So for those, they can be stuck very much in a hopeless, isolated state, and perhaps we've got to think of better ways of helping them. But we have to sort of, everybody's a bit different, and they might have autistic spectrum traits or a strong family history of depression, etc. That often the course of depression doesn't run the same time course as the eating disorder. People still have a lot of depression afterwards. So women in the Alsbach study who'd had anorexia early on, they had higher levels of depression throughout their pregnancy and then during the child's life, and then it increased a bit when the child was about 18. So and that would be a time coming into menopause when estrogen levels. So there's so many things we don't fully understand, but and we do sometimes see cases re-emerging at that sort of time.
It's a really puzzling illness that we've got so much more to learn about, and just in terms of sort of medications and maybe future kind of biological agents that could help. You mentioned, Janet, things like magic mushrooms and ketamine. What are the sorts of scientific advances around these things?
Well, people are very interested in those because they're very interested in treatment-resistant depression, and of course the depression of anorexia is treatment-resistant. Most people a standard antidepressant doesn't do anything for people with anorexia when they're underweight. So we're learning from our cousins who work in depression, who are now starting these treatment trials, and ketamine has been accepted as a very rapid antidepressant for depression. So there are some older studies of using it in anorexia, so we need to sort of try it out.
It sounds really interesting, and something really new to kind of look out for, you know, find out a bit more about the findings. And I guess as we wrap this up, I'd like just to hear from each of you what you think families, people with eating disorders and their loved ones, what you think the sort of take-home message for them would be around medications. What would be the one sort of gem of information, or the gist of information that you would like them to take away?
I think one important thing is not to restrict your therapeutic options too early. And we just had the case where someone gained all the weight but still had the typical anorexic fears, and maybe psychotherapy was added, family therapy was added, and if this all doesn't work, then it's important to think about other options, such as medication. And maybe in the future we have a range of medications like ketamine, or psychedelic medication, or maybe medication that enhances the effects of psychotherapy, like D-cycloserine or oxytocin, a hormone that's important in relationships. So the main message is to always keep your eyes open for novel treatment options, and not to restrict these options too early.
So keep your options open.
Yeah.
Thank you.